because I think let's begin this webinar, which is pertaining to endometrial cancer. I've been getting a lot of queries regarding the new staging and a lot of confusion related to the new staging system. So I thought let's discuss it over a webinar. So I think let's start, and I would encourage all of you to please keep answering and to keep please asking your questions on the chat. Let's make it as interactive as we can, because then it'll help all of us. So let's begin. So why endometrial cancer is important is because this is one of the most common gynecological malignancy encountered in the developed world. So developed world, I mean the UK and the US, this is the most prevalent gynecological malignancy. In India, the most common gynecological malignancy, somebody would like to answer on the chat is, yes, cancer cervix. And I think a few years back, cancer cervix was the most common cancer amongst women. And now it is cancer breast, yes. Cancer cervix is the most common gynecological malignancy. But if we look at overall malignancies, then cancer breast is the commonest malignancy encountered in women in India. Any reason why the Western world has overcome this cancer cervix? Any reason why you think that no longer cancer cervix is a health problem for them? Yes, because they have screening, a well-developed screening and vaccination program, which unfortunately we lack in India. So again, from perspective of a MRCG, because UK, the NHS screening program for carcinoma cervix, that is again a very important part which you should know for your MRCG exam. So as a result, cancer cervix, they have already overcome the problem, and now the most common malignancy, the gynecological malignancy, which is prevalent in the West or in the UK scenario, is the endometrial cancer. And what type of endometrial cancer is most common? It is the histological type. What histological type of endometrial cancer is commonest? Yes, the adenocarcinoma, the endometrioid cancer. And this is less aggressive than the non-endometrioid type of tumors. Also, the prognosis of endometrial cancer is quite good. And the reason for this is the most common presenting symptom in cases of endometrial cancer is, somebody would like to say, what is the most common presenting symptom? It is AUB, and this is something which will be very commonly noted and it will be reported to the doctor. So because AUB is the most common presentation, it is detected in an early stage. And as a result, the prognosis for endometrial cancer is extremely good. And there is nearly 90% 5 years survival, which is associated with endometrial cancer. So there are basically two types of endometrial cancers which are there. One is type 1 and the other is type 2. And type 1 is basically grade 1 and grade 2 endometrioid tumors. And type 2 could be grade 3 endometrioid tumors or non-endometrioid tumors, which could include clear cell carcinoma, serous carcinoma, it could be mesonephric type, it could be mixed cell type, it could be carcinosarcomas, or it could be gastrointestinal mucinous type. So those are the non-endometrioid tumors. So I also want you to remember that endometrioid tumors are the non-aggressive type. These are the non-aggressive tumors, whereas the type 2 tumors or the non-endometrioid type of tumors or the grade 3 endometrioid type, these are considered as aggressive tumors. And why I'm stressing so much on this is because your staging and your treatment subsequently will also depend upon what is your histological type of cancer, whether it is aggressive or it is non-aggressive. So that is important. Then type 1 is the type which is more common. So 80% of cases are type 1. It is less aggressive. The prognosis is better. It is less aggressive and it tends to occur in younger perimenopausal nulliparous women. And the tumors are obviously better differentiated. Whereas on the other hand, the type 2 tumors, they comprise 20% of the total cases. So they are less common. They are associated with a poor prognosis because obviously they are more aggressive and the tumors are also less well differentiated. Another important difference between type 1 and type 2 is that type 1 tumors are more estrogen dependent. And so usually they begin as endometrial hyperplasia. On the other hand, the type 2 tumors, they are non-estrogen dependent and they may begin in a background of atrophic endometritis. So now coming to the next slide, the clinical presentation of endometrial cancer. So as I told you, the most common clinical presentation, the symptom which is present in nearly 75 to 90% of women is abnormal uterine bleeding. Now, what is the age group in which this cancer is most commonly encountered? What is the age group of women? Do you encounter it in younger women like cervical cancer, or you encounter it in elderly women? Yes, it is almost 50 years to 75 years. So an average of 63 years is the average age for endometrial cancer. So women could be in the perimenopausal age group, they could be in the postmenopausal women. So if it is menopausal women who have this symptom, then this obviously would be postmenopausal bleeding. If it is women aged 45 years to menopause, then it could occur under various scenarios. There could be intermenstrual bleeding. There could be excessive bleeding during periods. So excessive bleeding means it is greater than 80 ml. Or it could be the duration of bleeding could be prolonged, so it could be greater than 7 days. Or it could be very frequent periods. So very frequent periods means what is the interval at which they are occurring? Less than or equal to 21 days interval. So this is if they are aged 45 years to menopause. If they are under the age of 45 years, then what could be the presentation? The presentation could be obviously in form of heavy menstrual bleeding. Plus, these are the people where you can have some exogenous or endogenous estrogenic exposure, which is resulting in this kind of condition. So there could be a situation associated with chronic and ovulation. So most commonly this is PCOS. There could be obesity because this is also an estrogenic condition. Or they could be taking some medications, maybe something like tamoxifen, which could be associated with excessive estrogen exposure. Again, even in these cases, you may have abnormal cervical cytology, that is through pap smear, but the sensitivity of this is very less. So it is just 45 to 55% with pap smear, and it may be 55 to 65% with thin prick. So again, this is not something which should be or is routinely done because the cervical cytology, it may detect some endometrial cells, some atypical glandular cells, but again, the sensitivity is not very great. What else? How else can she present? It could be an incidental finding on imaging. And how do you detect it on imaging? On imaging, that means it could be transvaginal sonography, it could be MRI examination, there could be thickened endometrial thickness or the endometrial thickness of greater than 4 millimeters. But again, this is applicable for postmenopausal women. This is not applicable for women who are in the perimenopausal or the premenopausal women. Because in those women, the endometrial thickness is obviously going to vary with the phases of menstrual cycle, and it would be obviously much greater than 4 millimeters. Again, this could also, you could have it as an incidental finding after hysterectomy. So if you are doing hysterectomy, due to AUB, then you should surely go ahead with a biopsy before you undertake hysterectomy. So clinical findings, any typical clinical findings which you encounter with this condition? So on physical examination, usually there will be no specific finding which you see. In some late stages of endometrial cancer, you may have an enlarged uterus or a fixed uterus. But again, that is in a very last stage, and sometimes you may not even find something like this, even in stage 3 or stage 4 disease. The lab findings, maybe she may present with anemia, especially if there is excessive bleeding which is occurring. Ultrasound, we spoke about that less than 4 millimeters is what the endometrial thickness should be in postmenopausal women. And it may be more than 4 millimeters and it almost may approach 20 millimeters in cases of post-menopausal women if they are having endometrial hyperplasia or an underlying cancer. Again, endometrial hyperplasia doesn't mean that she will have the malignancy. That entails that biopsy needs to be taken. Again, in the premenopausal patients, as we discussed, the endometrial thickness will not correlate with the cancer risk. So diagnosis, what is the short or the golden diagnostic methodology? Yes, it's the biopsy, and the gold standard would be probably, so how do you normally do endometrial biopsy? Peeplee biopsy or endometrial aspiration, that is what is routinely done. But again, with endometrial aspiration, the result would be positive only if more than 90% of the endometrium is involved. So you may, if nothing works or if endometrial aspiration is insufficient or it is unable to give you proper results, it is negative, or the tissue which you have sucked out is less, in that case, you will go ahead with hysteroscopic directed biopsy. That becomes the gold standard because you can examine it through hysteroscope and you can then take the directed biopsy from the affected area. So coming to the post-diagnostic management, once the diagnosis is made, what should you do in these cases? So if the woman is postmenopausal and she is not on hormone therapy, then you need to rule out any endogenous or exogenous source of estrogen, which could act as risk factor for the disease, because unopposed estrogen exposure is one of the most common risk factors for the disease. So you want to rule out any endogenous source of estrogen, and endogenous source of estrogen could be, there could be some tumor. And in this age group, what kind of tumor could be there? Sex cord Sertoli cell tumor. Okay, or it could be some exogenous source of estrogen. Again, we spoke about this, that she could be taking tamoxifen, or it could be that there is obesity. Then what is also important is testing for Lynch syndrome. Again, testing for Lynch syndrome is not done as a routine in the Indian scenario. But again, from the Western scenario, this becomes important. Now, why is this important? Why should you do testing for Lynch syndrome, and what is Lynch syndrome? So Lynch syndrome is basically a hereditary cancer syndrome, and if this exists in the women's family, then it may be associated with nearly 25 to 60% risk of developing endometrial cancer. And besides the risk for endometrial cancer, the women with Lynch syndrome, they would also be at risk of other cancers. And what are these other cancers? They could be cancer ovary, they could be colorectal cancer, they could be cancer small intestine, they could be cancer of stomach, they could be cancer of the urinary tract. So this is the cluster of cancer which could occur in the families. And if this cluster is occurring in a woman's family, then she has a 25 to 60% risk of developing endometrial cancer. And this is against the background risk. So risk of developing cancer in general population is about 2 to 3%. So this risk is increased almost by 10 to 15 folds if there is presence of Lynch syndrome. So that is why the screening becomes so very important. And again, the inheritance pattern of this is autosomal dominant inheritance. So how do you do the screening? Because the screening is done through testing for MMRD. What does MMRD stand for? Mismatch repairs defect. So there is a defect in the mismatch repair, and as a result of this, this predisposes the women to develop the cancer. And how do you detect this MMR defect? This is through analysis of four proteins. And what are these four proteins? MLH1, MSH2, MSH6, and PMS2. So again, this is important because this will also help you understand the molecular staging, which we'll be discussing in further slides. So universal screening for MMRD defect becomes important in women where you are suspecting Lynch syndrome. And this is because the defect in this repair may affect four proteins or four genes, and these are the four genes: MLH1, MSH2, MSH6, and PMS2. An abnormality of either of these genes could be encountered in women with endometrial cancer, especially if there is a history of familial clustering of cancers. So again, the ACOG, the RCOG, as well as the National Comprehensive Cancer Network, they are recommending the universal testing for mismatch repair proteins, or what is also known as microsatellite instability hypermutated in endometrial carcinoma amongst women, especially if there is a family history of Lynch syndrome associated cancer. So again, we discussed this, that the common pattern which may be encountered in women with endometrial cancer is, they could be, I told you there are four proteins, and out of these, the pattern which could be encountered in women with endometrial cancer is that they could be having loss of MLH1 and PMS2, or there could be loss of MSH6 and PMS2, or an isolated effect of MSH6 and isolated effect of MSH2. So either of these situations could be encountered in women who are having this Lynch syndrome. So again, it is important, once the diagnosis of endometrial cancer is made, it is important to do the staging, because only once appropriate staging is done, you can initiate correct treatment. And what kind of staging is done in cases of endometrial cancer? Is it surgical or is it clinical? Yes, it is a surgical staging. So that is important that you do surgical staging. So clinical staging is not that prevalent in these cases, or it's not unless surgery cannot be attempted. In those cases, you may have to undertake clinical staging, and that also mainly through the MRI examination and not through the clinical examination, because as we discussed previously, clinical examination will not reveal much significant findings. So in surgical staging, you have to obviously come to the stage of cancer, and also besides that, so one is cancer stage. So before you can initiate treatment, you need to know the cancer stage. You need to know whether it is, what is the histological type, whether it is aggressive or it is non-aggressive. Also, you need to know the grade. How do you determine the tumor grade? What is grade 1, 2, and 3? So grading is based on the presence of solid areas when you see the tumor cells under the microscope. So grade 1 will have less than or equal to 5% of solid areas. Grade 2 will have between 6 to 50% solid areas. And grade 3 will have more than 50% solid areas in it. And obviously when grade 3 tumor comes, it becomes the aggressive type. Grade 1 and grade 2 are the non-aggressive type. So this is also important. Why I am spending more time on this is because all this will help you understand the staging, because staging will include all these things. So I hope this is clear. And besides that, there is something which is the TCGA molecular staging which needs to be done. So you need to find the disease stage, the grade, the histology. We have discussed about the grade and histology and the stage. And also what needs to be done is the TCGA, which stands for the Cancer Genome Atlas molecular staging. And this we'll be discussing in the further slides. And again, this is important and this should be routinely done in all cases of cancer, because why should it be done? Because it affects the prognosis. If there is one of the molecular markers is present, which we'll again discuss in details, then it may result in upstaging or downstaging of the tumor which is present. And obviously, if upstaging means that whatever stage is there, you will increase the stage. And obviously, that means the disease become more advanced. Downstaging means that you reduce the stage. So it becomes less advanced. And as a result, the prognosis becomes better in this case. Better prognosis. And this becomes worse prognosis. Also, if you are upstaging a cancer, that means you are increasing the stage. It also means that you may have to go ahead with neoadjuvant therapy. So there is a question, the new FIGO staging, is the histological grade taken into account for every stage? Especially for stage 1, yes. Stage 2, it is not that significant, but stage 1, it is significant. We'll see it. We'll be discussing this in depth. So that is the reason why I am emphasizing so much on this, just to build the background so that when we start the staging system, you are able to understand it better. So again, the molecular markers, they are important for upstaging or downstaging. So that will determine the prognosis. Also, it will determine whether you have to give neoadjuvant therapy, that is after surgery. And this could be either in form of radiation or it could be in form of chemotherapy. Sorry, this is adjuvant, not neoadjuvant. Adjuvant therapy, whether needs to be given or not post surgery. So is screening for endometrial cancer done? Screening for endometrial cancer is not done because we don't have any test which is sensitive or specific enough. We discussed that the pap smear, the sensitivity is not much. For detection of cervical cancer, the sensitivity of pap smear is very high. But for detection of endometrial cancer, the sensitivity of pap smear is not that great. So you'll miss most of the cases. So there's no point of screening through pap smear. Also, we have done endometrial thickness. It is also not a very good screening methodology. But like we discussed, that screening should be done in cases of Lynch syndrome or hereditary syndromes like Cowden syndrome. And in those cases, how do you do screening? You do it through endometrial aspiration or endometrial sampling through Pepley device. And again, if you take biopsy routinely, or you do endometrial sampling routinely, then that becomes an invasive procedure for the general population. So you don't do it routinely in general population. Screening is done only in cases of the cluster syndromes like the Lynch syndrome or the Cowden syndrome. Again, with Cowden syndrome, the risk of development of endometrial cancer is only 5 to 10%. Whereas with Lynch syndrome, the risk of development of malignancy is 25 to 60%. So obviously, these cases, they become more important, the Lynch syndrome. The Cowden syndrome is not that important regarding the development of endometrial malignancy. So again, in these cases with Lynch syndrome, you need to do endometrial sampling, which will help in ruling out if they are suffering from endometrial cancer. So suspected patients with Lynch syndrome, they have a family history. Okay, or either of those, what we discussed, the genes, they are present in them. In those cases, you may have to do endometrial sampling. And you may also undertake a risk-reducing hysterectomy in these cases. And something similar you can also do in patients with Cowden syndrome. So now let's talk about staging and surgical treatment, that how do we go ahead with this. So pre-operative evaluation before you undertake the surgery, a medical and a surgical history should all obviously be taken to evaluate for comorbidities, because they may be hypertensive, they may have type 1 diabetes, especially if it is the type 1 endometrioid type, then because this is likely to be present in women who are hypertensive, diabetic, or those who have a higher BMI. A family history of cancer becomes important because then you'll be able to rule out if there is Lynch syndrome or Cowden syndrome, because in that case, then you have to be alert further. Then again, ultrasonography to determine the uterine size or the endometrial thickness. The imaging studies, you may undertake a chest X-ray to rule out metastasis to the lungs, especially if you're suspecting a very advanced disease. And abdominal and pelvic imaging can also be done to exclude metastasis from aggressive endometrial cancers. Additional chest imaging with CT may be performed to exclude metastasis if it is an aggressive endometrial cancer. And again, like I mentioned, that if in case you're not going ahead with surgical staging and you're going ahead with clinical staging, in that case, contrast enhanced MRI to detect myometrial invasion, cervical involvement, lymph node metastasis, and so on would be required. So, okay, now let's talk about the staging. So, as per the new FICO guidelines, so what do you mean by stage 1? So, any cancer stage 1 means that it is limited to that particular organ. So, if it is cervical cancer, it means it is limited to cervix. If it is ovarian cancer, that means it is limited to ovaries. If it is endometrial cancer, that means stage 1 is limited to uterine corpus. Then it can be further divided as stage 1A, 1B, and 1C. So what do you mean? What is 1A? So 1A means that it will be involving the endometrium or less than 50% of myometrium. So like somebody had asked me previously, so all these tumors are non-aggressive. So that is why the histological grading or the histological part becomes important. So these tumors are non-aggressive type. If they are aggressive, then the stage changes. So non-aggressive and there is no lymphovascular space involvement. Okay, 1B means more than 50% of myometrium will be involved. Again, it is non-aggressive and there will be no LVSI. And stage 1C means it is aggressive. Aggressive, and it will be involving just the endometrium, or if there is an endometrial polyp present, it might be just limited to that endometrial polyp. Okay, so I hope this is clear, that because stage 1 is the thing which is most complicated. 1A means it is limited to endometrium or to less than 50% of myometrium, and 1B means it is more than 50% or equal to 50% of myometrium, and 1C means it is an aggressive histological subtype which is limited only to the endometrium. And both 1A and 1B are the non-aggressive histological types, and there is no LVSI in them. So they are good prognosis tumors. So that you need to remember. Then if we go further back to my slide, then 1A can be further divided as 1A1, 1A2, and 1A3. So 1A1 means only endometrium is involved, and it is again non-aggressive, no LVSI. 1A2 means less than 50% of myometrium could also be involved besides the endometrium. Now 1A3 is where the trouble arises. So what is 1A3? 1A3 is involvement of the uterine corpus along the involvement of ovary. Now you'll tell me, if ovaries are involved, then that means the tumor has spread and it has gone to stage 3. But this is the new stage which they have introduced, which is 1A3, which is involvement of the uterine corpus and ovary, and how it differs from stage 3 is, I'll tell you. So in these cases of 1A3, obviously the myometrial involvement would be less than 50% because it is stage 1A. So it will be less than 50% of myometrial involvement. Also, there would be no LVSI. It will be non-aggressive type. And regarding the ovary, so in these cases, just superficial involvement of the ovary. So there will be no capsule rupture or invasion. So the capsule is intact, there will be just superficial involvement on the surface, and only one ovary will be involved. Only one ovary is involved. So this is important, and this is what is new in the new staging system. So they have introduced this new class which is 1A3, and this will also include the tumor involving the ovary, but it is a very superficial involvement. No invasion, no capsule rupture, no metastasis, no LVSI, no aggressive type tumor. So that finishes with stage 1. So before I move on to stage 2, another thing I would just like to repeat is that your non-aggressive tumors, so just before we move to stage 2, let's talk about what is aggressive and non-aggressive. Non-aggressive tumors is grade 1, grade 2, endometrioid type. Whereas grade 3 endometrioid type becomes aggressive. Or it could also include the aggressive type of tumors could include serous cell tumors, clear cell tumors, serous clear cell, mixed, mesonephric, gastrointestinal, mucinous type, or carcinosarcomas. So these are the various aggressive type of tumors, and non-aggressive would be grade 1 and grade 2 endometrioid type. So these are all the non-endometrioid type. So now let's move to stage 2. So stage 1, I told you that only it is limited to corpus uteri, and even if in stage 1A3 the ovaries are involved, it is very superficial involvement of the ovaries, and there is no direct invasion which is occurring. So stage 2 basically means that now from the uterine corpus, it has started extending slightly. The tumor has started slightly increasing, and it has started slightly growing more from being confined to uterine corpus. So it can involve the cervical stroma, or they could be lymphovascular space invasion, or they could be an aggressive type of tumor. We discussed what are the various aggressive types of tumors. So if it is involvement of cervical stroma, this becomes 2A. If it is LVSI, so if it is involvement of cervical stroma, that means this is non-aggressive type and there is no LVSI. But if there is LVSI, then that becomes 2B. And again, this is non-aggressive type. And if it is aggressive type of tumor, and it could be involvement of any thickness of myometrium, and it is an aggressive type of tumor, then that becomes 2C. So that is something which you should know, because then that becomes 2C. So that finishes with stage 2. So now let's revise stage 1 and stage 2 again. So stage 1, you know, is confined to the uterine corpus and ovary. And stage 1 is when it involves the endometrium and it involves less than half of myometrium. So it is involving the endometrium or less than half of myometrium. And 1B is more than 50% of myometrium is involved. And 1C is, it is because 1A and 1B are the non-aggressive type and there is no LVSI. But 1C is when the aggressiveness of the cancer increases and it becomes an aggressive histological type, but the involvement is just limited to the endometrium or to the endometrial polyp. So that becomes 1C. Then 1A can be further divided as 1A1, 1A2, 1A3. 1A1 is just involving the endometrium. 1A2 is involving less than half of myometrium. And 1A3 is involvement of ovary and the uterus. But again, all these tumors, they are all non-aggressive type and there is no LVSI. And then we talk about stage 2, where there could be involvement of cervical stroma, or they could be substantial LBSI, or it could be an aggressive histological type with myometrial invasion, and it could be any amount of myometrial invasion. So it could be the entire myometrium might be involved. That in that case, it becomes 2C. 2A is if there is involvement of cervical stroma, and 2B is when it is involvement of the LBSI, substantial LBSI. So that finishes stage 1 and stage 2. So now let's talk about the stage 3. So stage 3 means the tumor has spread out further. Now where all can it spread? So if the tumor is there in the endometrium, in the uterine cavity, where else can it spread? Stage 3. So it can spread to the serosa or the ovaries, the uterine serosa or the ovary, or it could spread to the parametrium or to the vaginal tissues or to pelvic peritoneum. Okay, or where else can it spread? It can spread to the lymph nodes. So lymph nodes could be pelvic lymph nodes, or it can spread to the paraaortic lymph nodes. So if there is involvement of uterine serosa or ovaries, then that becomes 3A. Okay, if it is involvement of either of these, parametrium, vaginal tissue, or pelvic peritoneum, it becomes 3B. If it is involvement of the lymph nodes, then it becomes stage, sorry, it should be 3 like this, 3C, 3B, and 3A. Okay, so if it is involvement of uterine, serosa, and ovary, it is 3A. Again, it could be 3A1 or it could be 3A2. So if it is involvement of the fallopian plus ovary, then it is 3A1. If it is involvement of the uterine, and this means involvement of the uterine serosa, which is through and through. Okay, uterine serosa, that is, it has invaded through the myometrium and it has involved, it has come out of the serosa. So through and through involvement of uterine serosa or involvement of the subserosa also. So that becomes 3A2. Okay, now coming to 3B. So again, if it is involvement of parametrial tissues or vagina, then that becomes 3B1. And 3B2 is if it is involvement of pelvic peritoneum. Okay, now if it is involvement of the pelvic, so that finishes 3B. Now if there is involvement of pelvic lymph nodes, then that becomes 3C1. And if it is involvement of the paraaortic lymph nodes, it becomes 3C2. Now this can be further divided based on whether it is micrometastasis or it is macrometastasis. So if it is, so this is pelvic lymph nodes and this is paraaortic lymph nodes. So if it is pelvic lymph nodes and there is micrometastasis, then that becomes 3C1, 1. And if it is macrometastasis, it becomes 3C1, 2. Similarly, if it is paraaortic lymph node, if it is micrometastasis, then that becomes 3C21. And if it is macrometastasis of paraaortic lymph nodes, then that becomes 3C2. Okay. So that finishes with stage 3. So if we again want to revise stage 3, then you know that stage 3 means that it has spread out from the uterus, and it could have involved the adnexa, or it could have involved the uterine serosa, or it could have involved the parametrial tissues or the vagina, or it could have involved the pelvic peritoneum, or there could be involvement of lymph nodes. So if it is lymph nodes involvement, it is 3C. If it is involvement of parametrium, vagina, or pelvic peritoneum, it is 3B. And 3A is if there is involvement of adnexa, that is fallopian tubes or ovaries or serosa, it is 3A. And based on that, you can divide it further. So now this is the FIGO staging. Now coming to the TCGA, which is the Cancer Genome Atlas Molecular Classification of Endometrial Cancer. So what are the 4 markers which you have to check in these cases? So first is the MMR, which is the mismatch repair, MMRD, or mismatch repair defect. And what are the 4 proteins which, or the 4 genes which you will be able to locate for MMRD? This is MLH1, MSH2, MSH6, PMS2. I had discussed this with Lynch syndrome, you'll remember this. So these are the 4 genes. Again, these are associated with MMRD or the mismatch repair defect. And these group of genes, they will also be required to be detected for the molecular classification of endometrial cancer. Okay, there is a query. Please explain differentiating between stage 1A3 and 3A involvement of the ovary. Okay, so I think let's go back before we further talk about the molecular classification. I'll clear these marking. Okay, so now you want to differentiate between stage 1A3 and you want to differentiate between stage 3A. This is your question. Okay, so let's so what do you mean by stage 1A? Stage 1A means involvement of the endometrium and less than 50% of myometrium. Everybody will agree to that. So stage 1A means that less than 50% of myometrium will be involved. And also there will be no LVSI. There will be no aggressive, it will be a non-aggressive tumor. There will be no metastasis. There will be involvement of only one ovary. And there will be no capsule involvement. So no rupture of the capsule is there and there is no invasion. So it will be just maybe over the ovaries, there might be just superficial involvement. Some tumor cells might be there. So that is stage 1A3. In stage 3A, it is that the tumor has actually invaded the ovaries or the adnexa or the fallopian tubes. Okay, plus the involvement of myometrium may be more than 50%. There could be a more aggressive tumor. There could be presence of metastasis. It could be through and through involvement through the serosa, plus involvement of more than one ovary. Both the ovaries could be involved, and there could also be growth over the ovary, that is the capsule could have been ruptured, or there could be an invasion which has occurred. So now have you understood the difference? Okay, great. So let's jump to the molecular, because I know that is something which is troubling all of you that why have they invented this molecular classification and made our life so difficult with this. So nothing to really worry about. Just so there are four molecular markers which need to be assessed for the TCGA classification. Okay, and the first is the MMRD, which I just discussed, and this stands for mismatch repair defect. And these are the four genes or four proteins which could be involved. And usually in endometrial cancer, there could be involvement of MLH1 plus PMS2, or there could be involvement of MSH6 and PMS2, or there could be an isolated effect of MSH2 and or just MSH6. The second marker which you need to assess for molecular classification is POL EDM or POL mutation. So what does POL stand for? POL stands for polymerase epsilon. And what does EDM stand for? EDM stands for exonuclease domain mutation. So that means there is a mutation in the exonuclease domain of the polymerase protein. And how do you detect this? Is through sequencing. Through genetic sequencing, you detect this, and usually what you assess is exon number 9 to 14. And the MMRD defect is usually detected through the immunohistochemistry. Then the third is NSMP, which is non-specific molecular profiling. Or this is known as P53 wild strain, WT or wild strain. And this is the low copy number. And the fourth is P53 abnormal or high copy number. And usually this you also detect through immunohistochemistry. And for NSMP or for P53 wild strain, usually the IHC number is +1. So this is +1. But if it is the P53 abnormal, then it could be either the score could be 0 or it could be +2. So if it is absent or if it is present in excessive amount, then both of it would be resulting in the abnormal P53. Or there is a high copy number. So let's further go into this. So when you do the molecular classification, you use a tool which is known as the PROMIS tool. And this PROMIS tool will actually assess all these four molecular defects which we just spoke about. So there is a question in any type of endometrial cancer, aggressive or endometrioid. So aggressive, it especially becomes important, but in ideally what the guidelines say is that it should be done in all the patients. And why it needs to be done in all the patients? Do we need to counsel the patient for complete TCGA, GCA? It is TCGA panel. Yes, we have to, because it will affect in two ways. And we discussed about this in the previous slides. One, it will affect the prognosis. And two, it will also affect whether you need to give the patient adjuvant therapy or not. So ideally, as per the European guidelines, they say that it should be administered in all the women. It might not be a scenario possible in India, but then in Indian scenario, we don't encounter endometrial cancer that rampantly. But for purpose of MRCOG, you need to do the complete TCGA panel. So now coming to the PROMIS tool. What does PROMIS stand for? It stands for Proactive Molecular Risk Classifier. molecular risk classifier for endometrial cancer. So this PROMISE tool will involve evaluating these four molecular subgroups. We discussed this: MMRD, the pole EDM or pole ultramutated, the NSMP or the P53 wild strain, and the P53 abnormal. So these four defects or these four molecular subgroups will be assessed through this PROMISE tool. So how do we go about assessing? So when you get a new sample, first you check for MMRD. This is the first thing which you check. The second thing which you check is the pole EDM, which we just discussed. The third thing, and we also discussed that the MMRD we checked using the IHC, the immunohistochemistry, whereas this you do genetic sequencing. Using the exons 9 to 14. And the P53, the wild strain or the P53 abnormal, we again assess using immunohistochemistry. And we also discussed in the previous slide that if IHC score is 0 or it is +2, then it becomes P53 abnormal. And if it is a score of +1, then it becomes P53 wild strain. Okay, now why is this molecular classification important? It should be encouraged in all cases of endometrial cancer, and this includes, so instead of pole EDM, because the previous classification they used the terminology pole EDM and now they are using as pole mutation. And whenever you put this, you put it as a subscript, the mutation. So why is this molecular classification important? Because it will help in deciding the prognosis. It will also help in upstaging or downstaging a particular cancer stage. And it will also help the oncologist in deciding whether you need to give adjuvant therapy to the woman. The risk stratification is the pole mutation or the pole EDM. That is something which is associated with good prognosis. So if this mutation is present, then usually the cancer gets downstaged. That is to a lower stage. And if there is P53 abnormality, then it is usually upstaged. That is, the staging increases. So it means it is a more aggressive or a more advanced state. So it is associated with a poor prognosis. And if it is MMRD or NSMP, then that means it is intermediate prognosis. Again, with MMRD, you have to keep Lynch syndrome in mind, and in that case, genetic counseling is something which becomes important because there may be a familial tendency and she may reveal a risk, and in these cases, you may undertake a prophylactic hysterectomy, or you can also do screening through endometrial aspiration. So coming to how the FIGO 23 staging, it changes with the molecular classification, because some I told you, and we have discussed it previously also. So there can be basically two ways how the classification changes. It could be stage 1A. So when there is a mutation, you put M, and you put in subscript, you put the pole, the mutation which is there. So it could be stage 1A pole mutation, and if this is present, then this is associated with good prognosis. And so it is one this, or it could be stage 2C PM P53 abnormal. So the mutation is always in a subscript, and you put M because that means molecular classification is also there. So in the same stage, you put a molecular classification also. So stage 2 CM P53 abnormal. So this is usually associated with a poorer prognosis if P53 abnormal is present. And usually in these cases, upstaging occurs. So how this occurs, we'll discuss it in this slide now. So any stage where the endometrial cancer, where you have found that the molecular classification, it reveals pole mutation to be present, and the tumor is confined to the uterine corpus, there could be extension to the cervix, but regardless of the degree of LVSI or histological type, you will stage it as stage 1A. So even if it is aggressive, because if you remember in the previous classification, without the molecular staging, stage 1A, it included the non-aggressive type. But if the pole mutation is there, even with the aggressive tumors, and only stage A3 was, stage 1A was completely non-aggressive, if you remember from this 23 FIGO staging. This is without using molecular staging. But when you use molecular staging, what happens is that if pole mutation is there and the tumor is confined to the uterine corpus, it could be with cervical extension. So that means it is stage 1A. But regardless of, even if LVSI is there or histological type is there, aggressive histological type is there, because otherwise aggressive histological type, as per our 23 staging, FIGO staging, this belongs to 1C, if you remember. So aggressive histological type, which is limited to the endometrium or to the endometrial polyp, that becomes stage 1C. But now the staging changes and it becomes 1A if pole mutation is present. So that means downstaging occurs in these cases and a lower staging system is assigned. So that means the prognosis becomes better in these cases. There's a query in the with cervical extension, will it be stage 1 or stage 2? This is why I was telling you that downstaging will occur, that if pole mutation is there, even if there is cervical extension and even if there is LVSI or there is an aggressive histological type, it will be downstage to stage 1A with pole mutation, because the prognosis turns better in these cases. And if it is carcinoma which is confined to the uterine corpus, it could be with any myometrial invasion, it could be with or without cervical invasion. Now again, this should be ideally to see irrespective of degree of LVSI or histological type. So if it is, if you remember stage 2, then with LVSI or with aggressive histological type, it becomes 2C. But 2A was just cervical invasion occurring. So if you remember 2A, it was cervical invasion and there was no LVSI and it was non-aggressive tumor. But now you have upstaged it to 2C. If there is P53 abnormality there, because this is more aggressive tumor. So if your molecular staging reveals P53 abnormal gene, okay, then it gets upstaged to 2C. Irrespective of whether what is the LVSI, irrespective of the histological type, even if it is, there is no LVSI or even if it is non-aggressive, it gets upstaged to 2C. with P53 because this kind of molecular marker is associated with more aggressive tumor and a poorer prognosis. So there is another question on the chat. Since ovarian cancer also has genetic predisposition, please don't give me another molecular classification for as it is, life has become difficult with this. We don't want another one for ovarian cancer. And more common involvement is BRCA gene, and that is not that BRCA gene is detected, but again, we don't have such an elaborate till now. They may have it in future that they may add the molecular classification to the FICO staging system and make it as complicated. But thankfully, till now, they haven't done it. Okay, so I hope now you've understood how the molecular classification will change will upstage it or downstage it. And if I again go to the previous slide, then now you'll remember that with pole mutation, the prognosis becomes good. There is intermediate prognosis with MMRD or with NSMP, and there is a poor prognosis with P53 abnormality. And therefore, with P53 abnormal molecular marker, there is upstaging. With pole mutation, there is downstaging which is occurring. Okay, now let's so if there is pole EDM, in rare cases there may be recurrence or advanced disease, because this we realized was better prognosis. So if they are unresponsive to conventional therapy and in rare cases there could be an advanced disease or recurrence, then you may give them option for immunotherapy in these patients. MMRD again, is associated with Lynch syndrome. So patients must be referred for hereditary carrier cancer counseling and testing options in immunotherapy. P53 wild strain, again, this was intermediate risk or not high risk. So these patients are associated with lower likelihood of metastatic disease, and they can be managed in the community with the help of hysterectomy and BSO or bilateral salpingo-oophorectomy. Then with P53 abnormal stain, fertility, because this is a very aggressive, if there is presence of P53 abnormal molecular marker in the molecular analysis or molecular classification, then that means the tumor is very aggressive. So such patients, aggressive tumor. So such patients, they should not be given fertility sparing treatment. And in these cases, complete or aggressive surgical staging must be done. And also these patients, there's a high likelihood of requiring chemoradiation. So this slide, this I took up, I told you before also that what are the aggressive histological types and the non-aggressive histological type. The non-aggressive histological type is grade 1 and grade 2 endometrioid cancer, whereas grade 3 endometrioid type becomes the aggressive histological type, and also this includes serous cell, clear cell, mixed cell, mesonephric, carcinosarcoma, gastrointestinal mucinous type. All these are the aggressive histological subtypes. And grading, also we discussed previously, it is based on the proportion of solid areas which are there in the tumor. So in grade 1, the proportion of solid area is less than or equal to 5%. If it is between 6 to 50%, it is grade 2. If it is more than 50%, it is grade 3. So how do we manage the cases of endometrial cancer? The management of cases of endometrial cancer is basically surgical. And this basically involves TAH with bilateral salpingo-oophorectomy. Now there comes an important question, whether we need to do lymph node dissection or lymph adenectomy or not. Again, that is something which we'll discuss, because this is more of a problem in stage 1 and probably mainly in stage 1 tumors, whether you need to go ahead with lymphadenectomy or not. In other stages, you have to go ahead because the tumor would be advanced, so you have to go ahead with bilateral pelvic or para-aortic lymphadenectomy, especially with stage 2 and stage 3 tumors. Stage 4 tumors, it's basically anterior and posterior accentration which is done, and stage 4B, it is usually non-operable, and you may go ahead with systemic therapeutic approach. It is basically palliative therapy which is given in stage 4. So now let's discuss in depth what happens in stage 1. Where should you do lymphadenectomy or lymph node dissection or not? So see, let's stage 1 cancers, they can be divided as low risk or intermediate risk type. The intermediate risk can be further divided as low intermediate risk and high intermediate risk. So low risk basically includes G1, G2 stage 1A, the low risk type. Okay, the low intermediate risk, it includes G3 stage 1A, and it also includes G1, G2 stage 1B. And the high risk type, it includes G3 stage 1B. Okay, now if it is low risk, then there is no need to do any lymph node dissection, or there is no need for any lymphadenectomy or lymph node dissection. And also there is no need for additional, because if the risk increases, then you may require additional therapy in form of radiotherapy, usually radiotherapy. But for low risk cases, there is no requirement for radiotherapy. And there is also no requirement for lymph node dissection. There is a concept of sentinel lymph node biopsy, which is being employed in cases of vulvar cancer also and in cases of endometrial cancer also. So what does sentinel lymph node biopsy mean? So sentinel lymph node is usually the first lymph node which is into which the cancer cells may drain. So that is the first lymph node which is draining into the tumor site. So if that is positive or it contains tumor cells, that means the rest, the lymph node dissection probably needs to be done, or lymphadenectomy needs to be performed. But in case the sentinel lymph node is negative for tumor cells, then that means the tumor has not yet spread to the lymph nodes, and you can forego lymphadenectomy in those cases. So how is sentinel lymph node biopsy done? It is usually done with the help of either radioactive dyes, radioactive material, which is usually technetium-99, is injected into the area which is surrounding the tumor, or it could be a dye which is injected. It could be a color dye like methylene blue or like indocyanine green dye. So a dye is injected or a radioactive substance is injected. If a dye is injected, then you'll be able to see the color. Okay, and then you'll be able to see the first lymph node which is draining the tumor site, and that is taken out. Or if you have injected the radioactive substance, then with the help of gamma probes, you'll be able to detect the where the radioactive material has traveled. And again, based on that, you can pick out the first lymph node which is draining the tumor site. and then you examine it under the microscope and you see if it has been infiltrated by tumor or not. So if the sentinel lymph node is negative for tumor, that means you can forego lymphadenectomy and the tumor has yet not involved the lymph nodes. But if it is positive, then you will have to undertake lymphadenectomy, because then it implies the dye is injected just around the tumor site. So it depends where the tumor is present. This is usually done when you're operating. Okay, so if it is low risk stage 1 or low risk tumor, then in that case, no radiotherapy, no lymph node dissection. But some agencies, especially the European bodies, they also suggest that in all cases of stage 1, you should do sentinel lymph node biopsy, which is not being really employed. So if sentinel lymph node biopsy, you can leave it also if you feel that there is no, it doesn't appear to be an aggressive tumor and there is very low likelihood of involvement of lymph nodes, then you can even, there is no need for sentinel lymph node biopsy in low risk cases. But the guidelines, the European guidelines, they say that it should be done. Okay, for all the cases of stage 1. Now, if it is the low intermediate risk or if it is high intermediate risk, in both these cases, you should do sentinel lymph node biopsy, and based on the results, then you can go ahead with lymphadenectomy. And also, if it is low intermediate risk, in this case, you should go ahead with brachytherapy following surgery so that the entire disease is taken care of. And in high risk cases, you can give external beam radiation therapy, which could be again pelvic radiation or it could be abdominal radiation. We'll discuss in next slide where all you need to give pelvic radiation and where all you need to give abdominal radiation. So now I hope things become clear to you that in stage 1, where all you need to do lymph node dissection and lymphadenectomy, that depends on the results of sentinel lymph node biopsy. And for low risk cases, there is no need to do sentinel lymph node biopsy also. But for intermediate, low risk and high intermediate risk, you need to do sentinel lymph node biopsy. So again, this is what I just told you has been explained in this flow chart. So you can see low risk could be stage G1 or G2 stage A1 and G3 stage A1 and G1 and G2 stage 1B becomes low intermediate risk and G3 stage 1B becomes high intermediate risk. And in both these cases, you need to do sentinel lymph node biopsy. And based on that result, you can go ahead with complete lymphadenectomy if biopsy is positive. In low risk cases, there is no requirement for lymphadenectomy. But some cases you can consider sentinel lymph node biopsy because the guidelines say that it should be done. But in reality, it is not being done. Then requirement for radiotherapy, I told you if it is low risk group, then no adjuvant radiotherapy is required. If it is low intermediate risk, you can go ahead with brachytherapy. If it is high intermediate risk, you can go ahead with external beam radiotherapy, which could be of two types. It could be abdominal radiation. So abdominal radiation would be given if there is intraperitoneal disease, or it could be pelvic radiation. So this we'll just discuss where all you need to give abdominal radiation and where all you need to give pelvic radiation. So requirement for radiotherapy in patients following initial treatment you know is TAH plus PSO. So if it is low risk disease, that is grade 1 and grade 2 stage 1A, there is only endometrial involvement or very superficial, minimal myometrial involvement, in that case, there's no need for any radiotherapy. Simple observation will do. If it is low risk intermediate type, that is, it is G2, G1 or G2 stage 1B, or it is G3 stage 1A. We discussed this in the previous slide. Then you go ahead with brachytherapy or vaginal irradiation. If it is deep myometrial invasion, or if there is spread to cervix, or if there are positive lymph nodes, in that case, you have to give pelvic radiotherapy with vaginal boost. And the field has to include positive paraiotic nodes also, extended field. And if there is adnexal spread, or if there is intraperitoneal disease, or there is a completely resected tumor, in that case, you have to give whole abdominal radiation. And if it is positive peritoneal cytology, obviously then it becomes stage 4, and in that case, you basically give progestins. So now the management modality, especially for endometrial cancers, now it has shifted towards the laparoscopic or the minimal invasive route. So total hysterectomy with bilateral salpingo-oophorectomy is what is the management of choice. Previously, exploratory laparotomy was done, and through laparotomy, the hysterectomy was being performed. But nowadays, majority of patients are being treated with minimal invasive surgery, either laparoscopy or robotic surgery. Both are working well for these patients. And this is obviously associated with better outcomes in relation to post-operative complication, duration of hospital stay. So post-operative outcomes are better with minimal invasive surgery, even in these cases. Now, there are two trials which you should remember. One is LAP2, which took place in 2009, and this is by the Gynecology Oncology Group. And the second is the LACE trial, which is in 2017, which stands for the laparoscopic approach for endometrial cancer. So both these studies, they said that the oncological outcomes, they are similar whether you go ahead with laparotomy or you go ahead with laparoscopy. The oncological outcomes and the duration of 5-year survival duration after surgery is same whether it is laparotomy or it is laparoscopic route, but the rates of perioperative and post-operative complications are much lower with minimal invasive surgery route, and this is also associated with better quality of life post-surgery. But you have to remember, while doing the minimal invasive surgery, the precautions which you need to take is that you should avoid any intraperitoneal tumor spillage should be avoided. So especially while you are taking the tumor or the uterus out, you should, one, avoid use of morcellator, the power morcellators, because you want to prevent the rupture of the tumor and you want to avoid the intraperitoneal tumor spillage. So you can adopt alternative routes, like you can have a mini laparotomy to take out the uterus, or you can use an endobag, but you should not use a morcellator. And also, if it is an extensive disease, there is metastasis which is beyond the uterus and cervix. In those cases, you should avoid minimally invasive surgery and you should go ahead with laparotomy. So stage 1 and 2, it is, you can adopt minimal invasive surgery very easily, but for stage 3 and further, you need to be careful and you should avoid minimal invasive surgery. So again, laparotomy may be required, especially if the size of the uterus is very high, the uterine size is very big, or the patient is unable to tolerate steep Trendelenburg's position. She might be very obese, or there is a known adhesive disease. There might be adhesions present due to previous surgery in the patient. In those cases, also minimal invasive surgery should be avoided. Then sometimes you can also adopt vaginal hysterectomy. And vaginal hysterectomy obviously is associated with improved outcome, and it is associated with lower rate of perioperative and postoperative complications. And this, however, you can use only in limited situations where the tumor is very limited in size and it has not spread to the peritoneal cavity or retroperitoneum. You need not assess that. So where the tumor is limited to the uterus and you are not suspecting, it is not an aggressive tumor and you are not suspecting the involvement of peritoneal cavity or retroperitoneum or other surfaces, in those cases you can also go ahead with vaginal hysterectomy. Now, lymph node involvement, I told you that nowadays what is commonly being used is sentinel lymph node biopsy. Previously, what was done was systemic lymph adenectomy was done in most patients based on suspicion, which nowadays is not required. Now, there is a trial which is known as the Aztec trial, which took place in 2009. And this stands for a study in treatment of endometrial cancer. So again, what did this compare was that bilateral lymphadenectomy versus removal of lymph nodes only if they appear suspicious. Again, at the discretion of the surgeon. So one thing which you should remember that till now there has been no good randomized trial related to sentinel lymph node biopsy and comparing it with bilateral lymphadenectomy. But still, sentinel lymph node biopsy has become the option of choice, even though there is no randomized trial available in its favor, or no randomized trial has been done till date regarding this. Still, it is taken as the gold standard right now. But this particular trial was comparing with complete lymphadenectomy versus removal of suspicious lymph nodes, and they realized that removal of suspicious lymph nodes was associated with much better outcome in comparison to complete lymphadenectomy. Lymphadenectomy itself can result in a lot of complications, so wherever possible you should avoid it. So factors which are used to determine the management of individual patient. So what is the probability if you feel that the lymph nodes would be involved, it's a very aggressive tumor and you feel the lymph nodes would be involved and it is spread majorly when you operate the person and you realize that it appears to be very aggressive, so it probably would have involved the lymph nodes. In that case, also the feasibility of surgery as accessing the lymph nodes. If you remove the lymph nodes completely, then the complication of lymphedema is something which the patient may encounter. So if patient is prepared to tolerate that, then you can think of removing the lymph nodes. Also, if she is okay with the use of adjuvant therapy, for example, radiation therapy, because if she refuses the use of adjuvant therapy, then there is no point doing lymph node evaluation or dissection, because even if it is positive, we will not be able to give her radiotherapy. So when will you anyway do bilateral pelvic and para-aortic lymphadenectomy is if there is an evidence of extensive disease, there is an extrauterine disease present, the tumor is grade 3, it is a non-endometrioid type endometrial cancer, it is an aggressive tumor, or it has involved a complete myometrial wall, more than 50%, then in that case, you will have to do, you cannot obviously do, even if you do sentinel lymph node biopsy, you will realize that it is positive and you probably would have to go ahead with bilateral pelvic and para-aortic lymphadenectomy. So what is the levels of lymph node dissection which needs to be done? So level 1 involves Internal, this is the lowest level, involving just the internal and external iliac group of lymph nodes. Level 2, you are also including the common iliac and the presacral group of lymph nodes. With level 3, you are moving further up and you are including the aortic inframesenteric group. And with level 4, you are including aortic infrarenal group. So fertility preservation, sometimes you may encounter a woman who wants to retain her uterus and she's been diagnosed, which will be a rare situation because again, endometrial cancer will be encountered very rarely in young women. Mostly it will be between 55 to 75 years of age. So usually such a situation will not occur, but if it does occur, then you can probably defer surgery and surgical staging until she's completed her childbearing. Until that time, you can just put her on progestin therapy. But you have to counsel her about the risk of recurrent or persistent disease, which is going to be higher in her case. So again, we had discussed this initially that if the patient is inoperable, because normally you will not ever do clinical staging in these cases, but if the patient is unfit for surgery, she might be having risk factors for anesthesia, she's very obese, or she's unwilling to undergo surgery. In that case, primary radiation therapy may be an acceptable treatment. And in those cases, the staging is done clinically and usually it is run through an enhanced MRI examination, because an enhanced MRI examination is likely to have 80 to 90% sensitivity of detecting myometrial invasion. So that was all for today's session. Now, if there are some doubts, I can take it up. So there is a question, what are the major areas of focus pertaining to endometrial cancer? For MRCOG1, you need not worry so much about it. MRCOG1, there might be maybe one or two SPs asking you about molecular classification or maybe the changes in the stage. But for MRCG part 2, you may have a complete EMQ based on the staging of endometrial cancer. So there is Aztec trial showed no significant difference between the two groups. Yes, so even removal of the suspicious lymph nodes and removal of complete lymphadenectomy was not associated with significant difference, but we don't have any. That is not what we are doing nowadays. We are doing sentinel lymph node biopsy, and for that there is no study which is available or no randomized trial which is available. The only trial which is available till now is Aztec trial, and that is also showing no difference between the two groups in terms of survival and in terms of the complication rate. You can have an EMQ on new classification. I'll not scare you, but because usually they will have one or two EMQs are pertaining to oncology, and they may ask you complete staging of one cancer, any one cancer. So it could be any of the cancers. So there is a probability, because the staging is new, you may be asked. Again, it is important at least to know about the staging. Okay, so thank you so much for being there.